The United Leukodystrophy Foundation presents Adult-onset Leukoencephalopathy, presented by Dr. Renaud of Mayo Clinic, Dr. Fatemi from the Kennedy Krieger Institute, and Dr. Wolfgang Koehler from the University of Leipzig.
Good morning and welcome to the United Leukodystrophy Foundation 2020 Family Conference. We'll be speaking first on adult-onset leukoencephalopathy. I'm Dr. Deborah Renaud, the director of the Neurometabolic Clinic and Leukodystrophy Program at the Mayo Clinic. I'll give you an overview of symptoms and an approach to adult-onset leukodystrophy, and I'll also talk about some of the leukodystrophies that affect both adults and children. We'll only touch on the individual leukodystrophies briefly, and I refer you to the agenda for the meeting for individual sessions on these leukodystrophies. The next speaker will be Dr. Wolfgang Koehler. He's from the Department of Neurology at the University Hospital in Leipzig, and he's a world-renowned expert in adult-onset leukoencephalopathies and adrenomyeloneuropathy. He'll talk about the predominantly adult-onset leukodystrophies. And then Dr. Ali Fatemi will finish. He is the Chief Medical Officer at the Kennedy Krieger Institute and Director of the Division of Neurogenetics in the Moser Center for Leukodystrophies. And he will talk on clinical trials in adult leukodystrophies, the challenges and opportunities. So let's start with a case because adults do present somewhat differently than children. So we have a 50-year-old female with a 4 to 5 year history of progressive cognitive decline and psychiatric symptoms. Prior to this, she was a healthy, university-educated manager of a department store and then became forgetful, disorganized, and inconsistent in her ability to do her activities of daily living. She developed progressive cognitive decline, which was characterized by a number of symptoms that would be suggestive of dementia, including short-term memory impairment, disorientation, and wandering from her home. She lost her abilities to write and read. She would confabulate, which means that she would make up things to try to answer questions when she didn't know the answer. She lost her ability to speak to the point where she spoke mostly in single words and 2 to 3 word combinations. She had echolalia in that she repeated what everyone said. Would perseverate and be tangential. She had difficulties with understanding and comprehension. She showed poor judgment and had inappropriate lability and uninhibited behavior. In addition to these symptoms, she had a significant change in her gait, which was stiffer and more unsteady. On her exam, her mini mental status examination had a score of 11 out of 30, which is a significant cognitive impairment. She was very uninhibited. Her cranial nerves, so the nerves in her face, were normal, but her gait was very stiff and clumsy, and she had increased tone in the legs with brisk reflexes. This is her MRI, and you can see diffuse abnormality of the white matter involving all aspects of the brain in the front and in the back. And she was diagnosed with adult-onset metachromatic leukodystrophy. Inherited leukoencephalopathies are individually rare, but at least 42 forms have been described in adults. And although most of the classic descriptions are the early onset or more severe forms that appear in children, we now know that the majority of these conditions have milder forms with both juvenile and adult onset phenotypes. They can be inherited in multiple ways. Recessive conditions involve mistakes in both copies of the gene and are usually inherited from both parents who are asymptomatic carriers. Dominant conditions are seen in successive generations and involve a mutation or mistake in one copy of the gene, often with a parent who is involved. X-linked conditions on the X chromosome, an example would be X-linked adrenoleukodystrophy, and sometimes the gene mistake is new and is not seen in other family members. The presentations in adults that are suggestive of leukodystrophy are somewhat different than in children. Psychiatric symptoms or changes in executive function may be the first symptoms and may precede other neurological symptoms by several years. And therefore, these individuals will present to a psychiatrist rather than to a neurologist. Cognitive decline or dementia is a common feature, particularly when it occurs in a younger adult. It should indicate a need to investigate for leukodystrophy. Changes in gait with spasticity or stiffness of the legs is a common finding in leukodystrophies, and this results from damage to the white matter of the brain, with increased muscle tone in the limbs, especially the legs, that limit motor function. It can be accompanied by increased reflexes and clonus, which is a beating at the feet or ankle, and scissoring of the legs, which is crossing when there is extension of the legs, can impair mobility and walking, and also transfers. There are many treatments for spasticity, although none are ideal. Benzodiazepines such as diazepam and clonazepam can help with stiffness in the legs and arms, but can cause drowsiness and drooling. Baclofen given orally can also cause drowsiness and weakness of the trunk. When the spasticity is primarily in the legs or the lower extremities, an intrathecal pump where baclofen is put into the spinal fluid can be very useful to help with spasticity in the legs. And when individual tight muscles are causing impairment, Botox or phenol injections can be very helpful. Physical therapy is important to maintain range of motion and to prevent contractures, which are fixed tightness in the legs or arms, such as the inability to completely extend at the knees. Physical therapy also improves gait, stance, and balance, and occupational therapy can improve activities of daily living and fine motor skills. Peripheral neuropathy can be seen in many of the leukodystrophies, and this is a disorder of the peripheral nerves, including the motor and sensory and autonomic nerves. The symptoms include numbness, weakness, and pain, and peripheral neuropathy can cause decreased deep tendon reflexes despite the presence of spasticity. Treatment of pain can be very complicated with peripheral neuropathy because it is often a progressive disorder. Analgesics such as Tylenol and NSAIDs can be used, but it's important to avoid narcotics, which will often make the pain more severe and harder to treat. Preventative medications can be used for pain to decrease the chronic aspect of the pain, such as gabapentin or Lyrica, amitriptyline, some seizure medications such as topiramate, and some of the antidepressants. Topical medications can be used as well, particularly if the pain is isolated to the feet or restricted areas. And these can include a number of the preventative medications and also pain-relieving medications such as lidocaine, ketamine, and CBD. Leukodystrophies often have bowel and bladder dysfunction and have many causes, including the autonomic dysfunction, myelopathy, which is involvement of the spinal cord, and the leukodystrophy itself. And you can get symptoms such as constipation, diarrhea, and incontinence of the stool. With the bladder, there's often urgency, incontinence, symptoms of neurogenic bladder, such as inability to empty, and erectile dysfunction. Other features can include seizures, vision and hearing loss, swallowing difficulties, breathing difficulties, skin manifestations, and adrenal insufficiency. The leukoencephalopathies can be divided in many ways based on a number of characterizations. I like to divide them this way, with the leukodystrophies involved with macrocephaly or enlargement of the head, including Alexander, which I will talk about, Canavan's disease, and megalencephalic leukodystrophy with subcortical cysts. Some of the classic leukodystrophies include metachromatic leukodystrophy, Krabbe's disease, X-linked adrenal leukodystrophy, and other peroxisomal disorders. The dysmyelinating disorders such as Pelizaeus-Merzbacher disease, which I'll touch on briefly. There are a number of disorders of B12 and folate metabolism, vanishing white matter disease, and cerebrotendinous xanthomatosis. There are disorders that are associated with small vessel involvement, such as CADASIL and CARASIL, which I will talk about. And Dr. Koehler will discuss the adult-onset autosomal dominant disorders following my presentation. So Alexander disease is rare, and there is a separate talk on the agenda on Alexander disease. The juvenile form shows slow development of bulbar symptoms, ataxia or unsteadiness and spasticity with a relative preservation of intelligence. In adults, individuals with Alexander disease have different presentations and often are seen in multiple sclerosis clinics. They have spasticity, ataxia, and an individual very unique characteristic of palatal myoclonus, where the palate in the mouth has jerking that is not easy to control. This is due to a mutation, often a brand new mutation in a gene called GFAP, which is the way to diagnose this disorder now using mutation analysis. In the past, a brain biopsy would be performed for Rosenthal fibers, and there are some treatment trials that will be discussed, but traditionally this has been a supportive treatment of symptoms. The MRI findings in an infant or a juvenile form is often an extent to frontal dominant white matter abnormality, but in adults, these white matter changes may be minimal or absent, and it is primarily an atrophy of the medulla in the brainstem, in the upper spinal cord, and individual pieces of the cerebellum called the dentate nucleus and cerebellopeduncles. This is an example of an MRI scan in a juvenile form of Alexander disease where you have white matter involvement in the frontal regions bilaterally. Vacuolating megalencephalic leukoencephalopathy with subcortical cysts, or MLC, is a rare recessive disorder. There is enlargement of the head with spasticity, ataxia, and cognitive decline, and this has recently been described in adults as well as children. And there is very extensive white matter involvement with temporal cysts, which are classic, and I'll show you this, and it's due to mutations in MLC1 in a gene that's associated called HEPA-CAM. And you can see here the very extensive white matter involvement in this individual with the classic temporal lobe cysts. Metachromatic leukodystrophy occurs in 1 in 40,000 to 1 in 100,000 individuals. In the juvenile form, teenagers will often present with school difficulties, gait clumsiness, and incontinence of the urine, and then they develop increased tone, intellectual deterioration, and difficulties with swallowing. In adults, it is usually a neuropsychiatric presentation with psychiatric symptoms that precede a frontal dementia. They eventually do get a gait disorder and peripheral neuropathy, as well as problems with vision and swallowing. There are multiple forms, with aryl sulfatase A being the most common. Aryl sulfatase A is measured in white blood cells, and mutations can be found now with testing. And you may be asked to have a urine sample for something called sulfatides, which are found in metachromatic leukodystrophy. Much of the treatment has been supportive, but for juvenile and adult patients with metachromatic leukodystrophy, if they are diagnosed in the pre-symptomatic or early phases, may be amenable to bone marrow or stem cell transplantation, and in some cases, gene therapy, which can stop the leukodystrophy. Krabbe's disease is present in about 1 in 100,000 individuals. The infantile form has a very classic presentation with irritability and hypersensitivity to stimuli, and they develop severe spasticity, peripheral neuropathy, hearing and vision loss. In the juvenile and adult forms, it can present like most any other leukodystrophy with cognitive and psychiatric deterioration, pyramidal signs, which includes spasticity and weakness, vision loss, and peripheral neuropathy. It's due to an enzyme called galactocerebrosidase deficiency, which is measured in white blood cells. And again, the mutation analysis can be performed. Most of the treatment is still supportive, but it may be possible to slow the progression with a bone marrow transplant in late onset, but only if performed early or before symptoms have been seen. Pelizaeus-Merzbacher disease is one of the X-linked conditions and is also approximately 1 in 100,000. The classic presentation in boys involves a rotatory type of eye movement with low body tone early on, and then a very slowly progressive disorder with spasticity and movements that the boys can't control. More recently, some adult onset forms have been described, and there's an X-linked spastic paraparesis disorder where there is stiffness and weakness of the legs, but no involvement of the brain, and also an adult onset Pelizaeus-Merzbacher disease with dementia and tremor. This is due to deficiency of PLP, and you can see that there is a near absence of white matter on this MRI. It's due to mutations or duplications in the PLP1 gene. And although treatment at this time is supportive, there are some research labs that are developing treatments for Pelizaeus-Merzbacher disease currently. Vanishing white matter is also a rare autosomal recessive condition and can onset anywhere from infancy to adulthood. There can be chronic progressive ataxia with milder forms, including just spastic paraparesis or a primary ovarian failure. And something that's very characteristic of this condition are episodes of rapid deterioration associated with febrile illnesses, fear, excitement, and minor head trauma. There are 5 genes that are associated with this condition. And basically, the MRI scan shows vanishing white matter over time, as I'll show you. Only mutation analysis can detect this condition. Treatment is supportive, and there currently is a treatment trial, which I believe Dr. Fatemi will discuss briefly. And as you can see, the white matter here is progressively vanishing after each episode. The disorders, there are a number of disorders of leukoencephalopathy that are associated with a small vessel vasculopathy. CADASIL is the most common of these, and that stands for cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. That's a real mouthful. These are due to dominant mutations in something called Notch3. We often see this in multiple generations in families. Presentation is in young or middle adulthood. When they present, there are often severe migraines that are very atypical or have aura with them, and they may precede recurrent ischemic events or transient ischemic events, also called mini strokes. And then there is a slow cognitive decline that may have a stepwise deterioration where there's a stroke-like event, and then there's cognitive decline following that. The treatment for this are the usual preventative measures that we use for what's called non-cardioembolic ischemic stroke, or in other words, strokes that are not due to blood clots coming from the heart. It's important not to use vasoconstrictive medications for the migraine, and this includes all of the triptans. And that's because there is already a blood vessel involvement, and therefore the triptans can, in fact, lead to a stroke-like event. Carousel presents the same way as CADASIL does, but is autosomal recessive, and therefore there are 2 mutations in this gene called HDRA1. There's a condition called retinal vasculopathy with cerebral leukodystrophy, and this highlights the importance of having an eye examination as part of the workup for leukoencephalopathy. This is due to mutations in something called TREX1 and usually starts in the 4th to 5th decade. There's a classic retinopathy in the back of the eyes, recurrent transient ischemic events or stroke-like episodes, migraine-type headaches, behavior and mood changes, and a progressive cognitive decline or dementia. The final condition I'll talk about before handing over to Dr. Koehler are the COL4A1 associated disorders. This inheritance is dominant when we see it in multiple family members often. Sometimes it is due to a brand new or a de novo mutation. There is only one member in the family. You can see a lot of different types of presentation with either a hemorrhagic stroke that occurs in utero, so prenatally, that leads to what's called porencephaly, or a hole in the brain. And when there is a stroke at any age, it can lead to weakness on one side of the body or hemiparesis and seizures. There's usually recurrent stroke-like episodes that lead to a cognitive decline or dementia. The blood vessels at the back of the eye are very tortuous. There are often cataracts and glaucoma, which needs to be treated to prevent vision loss. And there's the anterior part, or the frontal part of the eye has a characteristic abnormality that the ophthalmologist will detect. And there can be a large vessel involvement, which includes aneurysms in the carotid arteries and also other large vessels such as the aorta. And with that, I'd like to turn you over to Dr. Koehler.
So I hope that you all can hear me. I hope that you can hear me. So I'm not very happy about the fact that we can't see us personally this year, but I hope that this format will really gives you at least some information that you need for your personal situation. So I wanted to talk about adult-onset leukodystrophies. It seems important to know that leukodystrophies is not a single disease. This is I'm not happy with the technique here. Can you see me or hear me? Okay. How can I manage with the slides? Just forward it.
Hi, Dr. Koehler. If you want to go ahead and open, just open your presentation. We can hear you, we can see you. So if you want to put your presentation in present mode, we'll be able to see it from there.
Okay, very good.
Thank
you. What I want to say is, and this is very important, that leukodystrophy is not a single disease, it's a whole bunch of diseases. There are, let's say, 40 to 50 diseases which are all have a different pathogenesis, a reason why the white matter is diseased. In some of these diseases, you never get normal white matter. In other diseases, the normal white matter that is there will disease and will then go away. So what I want to say is that all of these diseases do have, because they have different reasons for their development, they all have different treatments. This is very important. So the prevalence of each leukodystrophy is, these are rare diseases. But taking all these diseases together, let's say all of the 40 or 50 diseases together, they have a prevalence like a very frequent disease like multiple sclerosis collectively. So it's a relevant problem that we have to address here. Well, there's another thing I want to mention. Let's say 20, 30 years ago, we saw that most of these leukodystrophies are only childhood diseases. In the meantime, we know that most of the diseases also have a prevalence in adulthood, either they occur in adulthood or they develop from childhood to adulthood. So it's also an adulthood medicine problem. And these are increasing diseases described in adulthood. The next point, which is very important, is that the disease doesn't look all the time the same. So one disease may have different, we call that phenotypes. So they can look different. We have childhood variants, we have also adulthood variants for the same disease. And this makes it very difficult to diagnose such a disease. For example, in this family tree, we can see here that in this family, there are a lot of neurological diagnoses were made. For example, encephalitis in a child, multiple sclerosis in some adults, or hereditary spastic paraparesis, which is also a genetic disease in some others. But in the end, it turns out these are all misdiagnosed people. This is a typical family history of an XALD family. So family history is something very important in genetic diseases, and you can help with this. So once you have the idea that it could be leukodystrophy, we of course look at the MRI and we see typical pattern. We see changes in the MRI that are quite typical for some diseases, for others not so typical, but we at least get an idea this could be a leukodystrophy, just not only from the clinical point of view, but also from the MRI point of view. And the next step, what we then should look is that, are there other organs involved in this disease? For example, peripheral nerves or the liver, the spleen, are there ocular signs? Dr. Renaud also told you something about ocular signs in some of these diseases. Are there psychiatric disorders coming with the white matter disease? And this gives you an idea what kind of leukodystrophy you will find. And then if you have this idea, then you go further and go straight for, let's say, targeted genetic testing or whole exome sequencing, what we do in a molecular genetic diagnosis. So then you can make a diagnosis. And there are good reasons to have a diagnosis in the leukodystrophy. As you know, this is a genetic disease. That means other family members, even the family members that are not yet born, will probably get the disease as well. So you need to know if this disease is in your family. The second thing is, once you know what kind of leukodystrophy yes, you have at least a clue what could the prognosis of this disease. And third, of course, most importantly, once you know the exact type of leukodystrophy, you may have a therapeutic option. For example, stem cell therapy in ALD, in MLD, or GLD, or Tay-Sachs, or an enzyme replacement therapy in MLD, and other therapies, up to gene therapy approaches that are coming up, for example, in ALD and maybe other diseases in the near future. So let's have a look at some examples. I think I have not the time for go too much into detail, but I will give you some highlights of some of the diseases. For example, the adult-onset autosomal dominant leukodystrophy is one of the 50 leukodystrophies that is frequently misdiagnosed. It's a disease that is with clearly adulthood onset in the 4th and 5th decade, and it starts with autonomic dysfunction in most of the patients, not in all, but in most of the patients. So you have a bladder or bowel dysfunction, or you have falls or orthostatic dysfunction. And later on, there is some kind of spastic gait abnormality, ataxia, intention tremor, and other neurological symptoms. And of course, you see changes in the MRI. The important thing is that these symptoms are not at least the autonomic symptoms are not very typical for for leukodystrophies. So these patients are frequently misdiagnosed. They say they have something else, what causes their bladder dysfunction or the autonomic dysfunction. So this is of course bad, that you have usually have a very late diagnosis in these patients. So a second example is the adulthood cerebral ALD. Tomorrow, or I think on Friday or Saturday, there will be another section on ALD, on AMN, so you can inform you much more in detail in this section. But I want to make some points in the cerebral ALD patient, because in this disease, the early detection of the diagnosis is absolutely crucial. Now, we usually have various phenotypes in adulthood. We have phenotypes that causes some gait abnormalities, spasticity in the legs. But in some cases, we have either primarily or secondary to the AMN, to the spastic paraparesis type, you see later on acute cerebral inflammatory destruction of the white matter. And this is extremely important to recognize these changes that are inflammatory very, very early. If you're not detected early, it will progress rapidly. Like you can see here, this is only 2 years apart, and you see the massive changes in these patients, which you can treat. In this stage, you can treat these patients with a stem cell therapy or maybe even gene therapy. But in this stage, it's absolutely too late. You cannot treat in this stage anymore. So it's crucial to have the diagnosis as early as possible. I give you an example in the family that I saw recently for a gentleman who turned up for the participation in the clinical trial for AMN. And then he told me something about his family history. There were three brothers and one sister, which was first seen in 20 years ago. And at that time, one of the brothers died from a childhood cerebral disease. This is a very devastating disease, which is leading to death within, let's say, 2 to 3 years. So one of the brothers died from childhood cerebral disease, and this was the reason why all the others were looked at. Do they have also the disease, yes or no? And all of them had the gene. All of the brothers and the sister had the gene. And one of the brothers, who were at that time, I think 10 years old, had very minor changes. And this boy was treated at that point, 20 years ago, by bone marrow transplantation. And the third brother, at that point, was completely normal. He has no neurological symptoms and normal MRI. And this brother turned up 20 years later in our center with memory loss, with some attention deficits, with gait disturbances, with leg weakness, bladder and sexual dysfunction. And he had his MRI showing this inflammatory cerebral disease. So this was right at the edge that we had the chance to transplant this patient and to rescue his life. But at the same time, the brother who was treated 20 years ago brought him to our center. And this brother, who was treated with bone marrow transplantation 20 years ago, was completely clinically normal, was a normal MRI. So what I wanted to say is, it's extremely important to have regular investigations at least once a year, an MRI, and see your neurologist to find or to detect cerebral inflammation as early as possible in this disease. So this is a disease with many phases. We have, of course, we have other problems like adrenal insufficiency, which are treatable, which is treatable, and early diagnosis may be life-saving. So we are also looking for newborn screening. We will hear more about this later during this meeting. And of course, it's very important to detect the disease for genetic counseling of the family. Well, the third disease I want to mention is adult-onset leukoencephalopathy with axonal spheroids and pigmented glia. Terrible. This disease has two names. The second name is hereditary diffuse leukoencephalopathy with axonal spheroids. This is a very long name, and I think for a very common disease, which is also clearly underdiagnosed. Why is this underdiagnosed? Because it's an adulthood onset disease, frequently coming with some symptoms that are not clearly associated with leukodystrophy. For example, primarily acute onset neurological symptoms, like in these patients here. There are 3 examples of patients that turn up with acute right-sided hemiplegia or stroke-like episodes. So all of these patients were considered to have a vascular problem, stroke problem, and they were treated for strokes. But in fact, they had no risk factors for stroke. So having a clinical picture on MRI like a stroke patient, but you don't have any kind of risk symptoms, should at least give you an idea that this could be a genetic disease like this. So I also tell you something about this disease because there's very early news that this disease may at a certain point may be treatable by hematopoietic stem cell therapy or bone marrow transplantation. So there are some reports on that recently, and we already transplanted 2 patients with this disease. And it looks like this disease may be stopped by this treatment. So the highlights of this disease are you have this disease is mimicking strokes, sometimes also Parkinson's disease. So you may miss the diagnosis. And then you see in these patients early dementia, and what is very impressive is the apraxia. Nearly all of the patients I know have a severe apraxia, which means that they remember how to open a bottle or to write a letter. But when you ask him to do that, they just can't do. So this is really a problem for the family. But this is in the later stage of the disease. So we have to prevent this and make, again, an early diagnosis and early treatment. The last disease I want to mention is adult-onset polyglucosan body disease, because this is a disease which is interesting also, because it's very frequently comes with sensomotor polyneuropathy. What does that mean? Polyneuropathy is a disease of the nerves in your hands and the feet, and you have tingling and numbness in feet and hands, which also can you have falling, some muscle weakness, walking disabilities, and even low blood pressure may be associated with polyneuropathy. So this is again a disease which is very typical for leukodystrophy that is combined with a central disease, the leukodystrophy, combined with a peripheral nervous system disease, which is the polyneuropathy. So, and again, this may mislead the diagnosis. So this is very important to look in young patients with polyneuropathy, which you cannot explain otherwise, and you see in MRI changes that you can also not explain, this could be the clue to look for this disease, which also can be relapsing, remitting, mimicking MS, and the MRI changes also mimicking MS. So this is an important disease in the differential diagnosis of multiple sclerosis. I think about CTX you will hear a little bit later on. I just want only here to mention you that this disease is a kind of has childhood and adulthood onset with many symptoms that are in summary quite typical. You see these cataracts in the eyes, you see these cholesterol deposits around the eyes or on the tendons for like here you see in this picture. So this is also a disease which is may have many symptoms, but it's very important to diagnose it early enough because a treatment is available, and you will hear a little bit later on the treatment later on. So CTX should be considered in patients with major cataracts and xanthomas, which are these cholesterol deposits. You can easily diagnose it in the blood and confirm the diagnosis by genetic testing. And you can also prevent the complications by a certain treatment which is available, which is approved available treatment currently. So these are my slides, and thank you for your attention. Maybe you have some question later on. Ali, it's your turn.
Oh, can people hear me now? Okay. So I'm just waiting for my slides. Perfect. All right, let's get started. Thanks, Wolfgang, and thanks, Deb, for the nice presentations. What I'm going to try to do is talk a little more general terms and talk about what a clinical trial really means, and then try to talk about different therapeutic strategies and touch on some of the diseases that were just mentioned earlier. So first, what is a clinical trial? A clinical trial is basically when we do experimentation in humans. And it can either be an interventional study or it can be an observational study. Typically, when we say clinical trial, we're talking about an interventional study. And there's different forms of interventions, and there is different levels of trials. So that's a very important distinction that everybody should understand. There is what we call typically a phase 1, 2, and 3. But actually, there's also a phase 0 and a phase 4. Phase 0 really means this is the very first time, what we call a first-in-human trial, that you're injecting something, a drug or a device, into an individual. And all you're trying to do right now is to try to understand about its pharmacokinetics, how does it distribute in the body, where does it go, how is it secreted. Usually these phase 0 studies are combined with a phase 1 study, where you also aim to study the safety in a smaller scale group. So typically these studies are small studies with a handful of patients where you're trying to say, okay, this is the first in human trial. Is this drug safe? Is this going to kill people right away? Or does it seem to be, at least in the short term, relatively safe so that it can then be further pursued? And then when you try to look at the effectiveness, that's either a phase 2 or a phase 3 trial. A phase 2 trial is typically what we call a small effectiveness trial that's typically open label, meaning everybody is getting a drug and you're just trying to see, is there any effect there towards patients getting better? If you really want to see if something is working, the main issue is that you need to blind people, and we get into that in a second. So that's what we call typically a randomized placebo-controlled trial or a phase 3 trial. Once typically a drug is approved, and typically a drug is not receiving market approval, meaning it's not accessible through insurance companies and so on, until you get at least to this level, and then the regulatory agencies like the Food and Drug Administration or the European equivalents could approve it. And typically, even after the approval, there is often what we call a phase 4 trial, where you don't really still know the long-term safety of a drug, and so you study that for decades, sometimes in a large number of people. Why does this matter? What is the goal? Well, we need to really think about it, especially in the rare disease group. It's really challenging because there's just not enough patients there, and the diseases are rare, and we don't know the variability in the person. So it may be that what you're expecting is actually the natural course of a disease rather than your treatment, because each of these diseases, as you just heard, have different kind of forms and phases. So one of the main things is that we need to think about what is the goal of the trial. Are we trying to reverse symptoms? Are we trying to get somebody who's in a wheelchair to stand up and walk again? Or are we just trying to slow down the disease progression? What is more realistic based on the underlying disease pathology? And what is supposed to actually get better? Is it gait? Is it strength? Is it speech? And for each of these diseases, there's other variables that we have to figure out that are the most representative and most clinically relevant variables. And then lastly, I want to talk about placebo, because that's really important effect that we see. It's a natural effect. It's always there. So what is a placebo effect? Basically, it's a response to medical intervention which results from the intervention and not the mechanism of action of that intervention. So here's an example. This lady is looking at these pills and says, oh, these capsules look fabulous. When I look at the box, I already stopped coughing. And I'm sure you've gone through that process if you have kids yourself, that you often give them something, so it's going to make you feel better, and truly they feel better. And actually, this has been done in trials and shown that there's about a 30% placebo effect on average when you give people anything like a sugar pill. So that's important that we address that issue by trying to blind people. You always want to try to blind the investigator. You don't want the physician or the investigator who's giving the drug to know what they're actually doing, because there is lots of biases that they will develop. For instance, the treatment A might be something new and exciting. So inherently, if I'm giving somebody treatment A, I'm going to say, oh, this is going to work. This is going to work for sure better than the current treatment. Or it may be that you're going to give treatment A to somebody who's healthier and treatment B to somebody who's sicker. So now you're introducing a scientific bias here in terms of your analysis. And that's why being really placebo-controlled is the best and cleanest trial design to really understand if something is working or not. So again, this is a gold standard, and the challenge with this gold standard of having the investigator and the patient be blinded is very challenging. And in a rare disorder, because we just don't have enough patients, we don't even have enough experts, and so oftentimes that's really something where we need to think out of the box. For instance, in a traditional setting, you have a person getting placebo and a person getting the drug. In a rare disease, well, tough luck on trying to convince people to go on a placebo, because it's going to be hard to really ethically justify it. So what we often end up doing is we try to skew this by saying, okay, for every 2 people who get the drug, 1 person will get the placebo. And so that way your chances of getting the drug when you enroll in the trial is actually higher than 50-50. And hopefully by then you will be more motivated to participate. So that's, for instance, one of the ways to do it. Other ways to do it, depending on the disease, is potentially a crossover. But then also many of the new interventions, they are relatively invasive, like you heard, bone marrow transplantation, gene therapy. These are not studies where you can actually do a placebo. And so when you can't do a placebo group, what really matters then is to really have good natural history data that is reliable from people who were not treated, so that you can use those untreated people from the past, essentially, as your control group. And the regulatory agencies are very, very tough on that. If you want to do that, you have to have a very nice sort of outline as to how you're going to do that. And that's why it's also very important for any patient who's currently not receiving treatment to still participate in research, so that we can capture that data so that we can serve it for the future trials that will come as a control group potentially. So now I'm going to shift gears and talk about how do we fix a genetic disease, and that's by itself really a challenging problem. So there's different levels how we can fix it. I'm going to just briefly say, what is a genetic disease? A genetic disease is a disease where you have a change in a gene in your DNA, and that change in your DNA results in an abnormality in the product of that gene, which is typically a protein or an enzyme. And that abnormal product then is resulting in disease, in leukodystrophy. So one way to try to do it is to try to fix the gene or protein defect to prevent the onset of the disease in the first place. Another way to try to do it is to try to arrest the progression of the disease, for instance, by giving the patient small molecules that will fix the cellular abnormality that's happening, that's resulting in the disease. The other approach is then to say, well, the damage has already happened, let's try to come and restore. And so I think that's sort of the Hail Mary, Holy Grail kind of situation, where it's much harder to do that for things that have already been destroyed, to basically rebuild the body again. And so another way to do this is to try to come up with molecules that can sort of overcome the abnormal biochemistry or pathophysiology in the process. So I'm going to go through these briefly over a few minutes. And results of the so when you have a gene mutation, it actually can have different consequences. So one consequence is that mutation, that misspelling in the gene, results in no product. So you have a recipe for a cookie, and that recipe is missing the flour, so you're never going to get a cookie. Or you may have a misspelling and so as a misspelling, your cookie doesn't become sweet but salty. So depending on whether you have no product or a less active product, your approach is different than when you have a product that's altered in function. Because when you don't have a product or less active product, all you need to do is just replace it with a gene. So you just need to bring that correct gene, a copy of the correct gene, into the body of that person. On the other hand, if the gene is there and it's making you a salty cookie, you can't just bring in a healthy cookie because you still have the salty cookie. So you're going to have to somehow shut down that recipe. And so that's called gene silencing, or you can do that most recently with gene editing techniques, although that's still developing. So I'm going to go into that in a little bit. So when we talk about gene therapy, typically what we mean is gene delivery. Either we inject the patient directly with a virus that has the correct gene into their body, and there are some examples of that happening right now in some diseases, although none of them are actually yet leukodystrophies in people, but in animals. And then on the other end, what is happening right now in patients is what we call an ex vivo gene therapy, where you get the bone marrow stem cells, for instance, of an ALD patient or an MLD patient. You take them into the dish, you infect them with the virus, you fix the gene, and then you give them back their own cells. So rather than getting somebody else's bone marrow cells, they're getting their own bone marrow cells and have less of a side effect. So there are different gene therapy strategies that are out there. The challenges with all this is that, especially if you want to get a virus into the body of somebody, we have a big brain, we have a big nervous system, we have the biggest brains, in fact, after elephants. And so how are you going to get these viruses into these and distribute it all along? So that's the big challenge that people are typically facing, especially if you inject it into the vein. It may not go to the places you want it to. It may go actually to the wrong places where you don't want that gene to go. And so the other issue is that when you inject anything into your body may start an immune response against it and build antibodies against that virus, and that's going to defeat the whole purpose. And so, yeah, we talked about the size. So just here, give an example that there's a disease called Canavan, which was the first leukodystrophy where there was a gene therapy trial that was attempted, although it's still not fixing this disease. And most likely part of the challenge was the distribution. Even though it was injected in 6 different areas in the brain, it didn't stop the disease. The other way is now to say, okay, what about those diseases where there's too much of the gene? So how do we kind of, or you have a mutation that has altered function? Can we shut down that abnormal gene? And that strategy is called antisense oligonucleotide therapy, ASO. So basically, each gene has a copy. In order for it to become a protein, there is a copy made, which is called the messenger RNA, and that messenger RNA is then translated into a protein. You can put another piece of small RNA that will basically block this messenger RNA and will therefore shut down the protein production. So that's a strategy that's currently being involved specifically for Alexander disease, because in Alexander disease, for instance, we have a mutation in a gene called GFAP that results in too much of the GFAP that doesn't work well. And so the idea is to basically shut it down by using these ASOs. The problem is that these little ASOs are limited in terms of how far they can go into your body right now. So we need to have a mechanism that allows these to distribute throughout the body without being basically chewed up by our immune system. And also sometimes we want to get it only in a specific cell type and not shut down the gene everywhere. And so that's the other challenges that we are dealing with. But nevertheless, this is moving along quickly right now towards clinical trials, this strategy. And in terms of gene editing, everybody has heard CRISPR. I'm just going to say that this is not yet ready for human in vivo trials. But the methodology here is that you basically use an ancient system that we have in our body that is able to go and actually chip away the DNA and replace it with another piece of DNA. And so when you can basically replace single bases of your DNA with a very specific strategy here, but there's just lots of mechanical and technical issues that come up with this method still. Now I'm going to move quickly forward to a couple examples of small molecule therapies, so overcoming the pathophysiology. And you heard about CTX, cerebrotendinous xanthomatosis. This is a disease that has now a treatment. It's a disease basically where you have a mutation in a gene that results in this enzyme to not function. And when this enzyme that's called sterol 27-hydroxylase doesn't function, so you see that red arrow, as a result, you get some byproducts that get increased, and those are presumably toxic. One way to do this is by giving these patients chenodeoxycholic acid, which then actually inhibits has a negative feedback loop and stops these overt synthesis of these byproducts that we don't want to have. Now, we've not seen with this therapy anybody getting better. However, it does seem to slow down disease progression or stop it if you start it early on in life. So that's one treatment strategy, for instance. Another example is in Vanishing white matter disease. You heard about that disease. That's a disease that's due to a mutation in this complex gene that is basically 5 different proteins that build this complex called EAF2B. And so these mutations result in these complexes not being able to aggregate correctly. And there's a drug called the ISRIP, ISR inhibitor, which is basically this ring-like molecule that goes in the center of this ring molecule and brings this aggregate together and keeps it together. So that's a treatment strategy that's, again, irrespective of the actual mutations, potentially. And I want to finish up by just mentioning restorative therapies, of course, stem cell therapy in terms of injecting stem cells into the brain for them to become actually cells that replace the destroyed tissue. That's sort of, like I said, a little bit of a Hail Mary study. Several trials in that realm have been done worldwide so far. The cleanest one was done, I think, in the US about 5-6 years ago, where neural stem cells were directly injected into Pernicious-Metzbacher disease patients. And there seemed to be some evidence that maybe it was at least slowing down disease progression or not. Although, again, there was no control group here. So it makes it really hard to know if this is actually the way the disease would have turned out anyway or not. And it was a very small group of patients. There's always concerns about cancer when you inject stem cells into somebody that they may build tumors. Also, getting these stem cells is not easy. Especially if they're derived from fetal tissue. So that actually those issues resulted in the company then filing bankruptcy and it no longer exists. So I'm going to end up by saying that, if you have a disease and you're trying to figure out if there is any clinical trials, where do I find that information? The ULF has some information. You can also go always to the clinicaltrials.gov, which is a website where you type in your disease and you can see all studies essentially registered worldwide in there. It often lists the inclusion criteria, the exclusion criteria, and also has always a contact person there, so you can reach out directly to those investigators or to those drug companies. And I'm going to stop here so we can have a couple of minutes left, hopefully, for questions. And I'm looking at the questions right now. So I see one question is, what is the process to participate in a clinical trial? Should we request a doctor to reach out to the organization that's conducting the trial? That's typically what we do. What we do as physicians is that when we have a patient who we diagnose with a disease, say, remember Dr. Wolfgang Koehler just talked about ALSP, where you can get a bone marrow transplantation. So for instance, I know at least in one center in the US that's currently doing a study there. And so if I diagnose a patient with ALSP, what I typically do is I know those investigators and I reach out directly to them and say, I have a patient for you. And then, they kind of take over. But you can always ask your physician to reach out on your behalf. You can also reach out directly to that contact that's provided on the clinicaltrials.gov website.
All right, thank you so much, Dr. Fatemi, Dr. Renaud, and Dr. Koehler. That is all the time that we have for today. Thank you so much for joining us for this session, and we hope that we will get to see you guys in Chicago next year.
Thank you all.